All right. My name is Brian Havens. This is my presentation for the diagnostic module for SET 101. My presentation is going to be over SLAP and Bankart tears. So without further ado, here we go. Pardon me as I have something in my eye. So again, this particular presentation will be over SLAP and Bankart tears, and we'll talk a little bit about exactly what that means. I'm also going to talk a little bit fast because I've timed myself 3 or 4 times and I keep going over time. So I'm going to try to speed that up a little bit. So please forgive any brevity on my part. So a brief introduction. SLAP and Bankart tears are both specific injurious tears to the glenoid labrum. I'm going to do my best in the following slides to explain exactly what that means, how they happen, treatment modalities, prognoses, etc. So a quick rundown of different joint types. This is some, not all, of the joint types in the human body. Hinge, pivot, gliding, ball and socket. So for hinge, your example would be like the elbow or the knee. It tends to move really well in this one kind of hinging position, like a door hinge. Pivot joints, your best example is the atlas and the axis. Lets me move like this. Gliding joints, tarsal joint of the ankle. It tends to do a good job of gliding. It's not so good at rotating and such. Pardon as I just ate dinner. Ball and socket joint. So your best examples are the shoulder and the hip, and that's a little bit closer, more near and dear to what we're going to talk about. So ball and socket joints, also known as spheroidal joints, allow for a greater range of motion than the other joint types. They're unique for a couple of reasons. One being that greater range of motion, and we'll talk a little bit about the trade-offs involved in that, and then also the presence of a labrum. A labrum is a fibrocartilaginous structure that forms a rim in and around the recess of the socket of the joint. It's one thing to say that, it's another thing to look at it, and so we'll show some pictures and look at that here in a little bit. Both the shoulder and the hip have their own labra. We'll look at pictures of those, where they're located, what they're called, etc. So the hip labrum is also known as the acetabular labrum. So over here on the left, we have this number 5, and it's vaguely pointing into that articular space, and the number 5 is intended to point at the acetabular labrum, which is the name of the labrum of the hip. And then here on the bottom right, this kind of rimming surface around the kind of gray thing that runs around it, like a rim, a little circle, that is the shoulder labrum, also known as the glenoid labrum. So again, we have the location of the labra, the shoulder and the hip labrum. Both perform similar functions. They help to stabilize the joints and allow for a greater range of stable motion, respectively in the shoulder and the hip. Injuries can occur to both. Again, for this particular presentation, we're focusing on Bankart and SLAP lesions, which occur to the shoulder labrum. So we're going to kind of contain our conversation to that for the most part. So the glenoid labrum will be the focus of the rest of this conversation because that is the site of the Bankart and SLAP lesions. We'll look at a couple of pictures really quick. So here on the left, we have a sort of lateral view onto the scapula. So we see the glenoid labrum, glenoid cavity. Here on the far left, we see a lesion, a posterior lesion of the glenoid labrum. And then on the bottom right, we see what looks like a complete tear or rupture of the glenoid labrum, kind of in the Bankart region. And then we've got a couple of views that I chose because I liked them. This is an anterior view looking onto the skeleton. And so what I did for this view is I took out all the muscle tissues, all the connective tissues, except for the glenoid labrum. So here you have a really clean look at just the skeleton and the labrum itself. And so we see here anterior view, and the labrum is labeled for the audience, and it is also highlighted in green just to make its appearance a little bit easier. So what we'll do for the next one is we're going to pull the humerus out of the picture so you can see it a little bit more cleanly. And so we see that sort of empty space, the socket, the ball and socket, is the glenoid fossa, and I'll refer to that several times throughout the discussion. And then again, the part highlighted in green, little semicircular part, is the glenoid labrum itself. So this particular view is from an anterior position, and we'll do the same thing from a posterolateral view. And we see again, highlighted in green is the labrum, which is attached to the scapula. You can kind of see the glenoid fossa there, and then we'll remove the humerus. And you see, again, it's kind of the same thing we saw from the front, we're now seeing from the back. And this image drove home for me particularly how I tend to think of the shoulder as like the shoulder. I think of it here. But this image really drove home for me that the socket of the ball and socket joint is the little wing on the back. You know what I mean? It's my shoulder blade. And maybe that sounds naive, but seeing this image really drove home for me that I tend to think of this as the shoulder, but this is the humerus. The shoulder is this huge multi-part mechanism that involves a whole bunch of different moving parts. And we'll get into that a little bit. And then here, a better labeled version. You've got the glenoid labrum, glenoid fossa, scapula, which are all terms that I'll use throughout the presentation. So it's good to have them defined. And then I chose this particular image, which is called an exploded view, because it shows really well. You've got the scapula, the glenoid fossa, and then again, highlighted in green and sort of pulled out and separated, you have the labrum. The glenoid labrum plays a number of roles in the function of the shoulder. It centers and stabilizes the humerus. So it centers and stabilizes the ball in the socket. As part of that, it prevents that humerus from migrating too far outside of the socket. So it keeps the ball in the socket, basically. It also increases the width of the socket by about 50%. So not only does it keep the ball in the socket, it makes the socket wider and bigger. So in all these different ways, it's contributing to stability of that joint. It also, interestingly, and we'll look at this a little bit later, it serves as an attachment point for the long head of the bicep. And we'll touch on that a little bit in coming slides. This is a short little video that shows kind of the etiology and the function of it. And I wanted to take a look at this really quick. So we see this interior view of the shoulder. We're going to zoom in. And here in a second, we're going to see the shoulder dislocate interiorly, right? And then subsequent to that, we see, as we look in, a little bit of a tear here on the inferior and anterior parts of the labrum, what looks like a Bankart tear. And so it's just kind of showing the function, like how exactly these things come about. There we go. All right, so in all joints, there is a necessary trade-off between stability and mobility. Again, for joints like the elbow, you get this really good range of motion in this one plane. The elbow does really well in this plane. It doesn't tend to do so well as soon as you start twisting and turning it. It's not meant to do that to the same degree. The shoulder is really unique in that it has struck that balance between stability and mobility really far in one direction. It's really hedged its bets in favor of mobility. And that's why you tend to get these really big sweeping motions that are capable at the shoulder. You think about, again, people serving a tennis ball or pitching a baseball or swimming. All these things are really interesting and they require a huge range of mobility. Part of the trade-off there is that in being so highly mobile, the shoulder sacrifices a little bit of its security in being stable. And I think that's a really interesting thing about the shoulder. So it's really, really dependent for its ongoing stability on all these surrounding soft tissues. And what we'll see is when you get a tear in one of those, you tend to have pretty subsequently poor outcomes. A particular statistic I saw that I thought was really interesting. So if you look at the ball in the socket, only about 25 to 30% of the humeral head is in contact with the glenoid at any given time. So in other words, of the ball in the socket, only about 25 to 30% of the ball is in contact with the socket at any given time. So about 70 to 75% is not in contact. And again, most of the joint is not in contact with the other side of the joint. Again, it's so reliant on the soft tissues around it to stabilize it. And again, that's what makes the joint capable of all these wild motions. It also makes it uniquely vulnerable to stability issues. A number of ways to injure the labrum: shoulder dislocation, pretty obvious; acute trauma, typically from falls; repetitive strain from overhead sports. So I touched on this a little bit: volleyball, tennis, baseball, rock climbing, etc. And then high force movements, so particularly holding or sustaining weights out from the body. So things like bench presses tend to put a lot of strain on the labrum itself. In some cases, you do see with slight or moderate tears of the labrum, because of all of the other surrounding soft tissues, the shoulder itself can still be stabilized despite a tear in something like the labrum, because the other subsequent soft tissue layers are able to, in totality, kind of keep that thing together. As the tears get more severe, though, that's not really a possibility, and the end result is that you get shoulder instability. As far as risk factors, you've got two primary risk factors for labral injury, and they're both pretty straightforward. Repetitive overhead motion, so again, you're sporting, you're serving, you're swimming, you're throwing a baseball, you're rock climbing. And then the other one is increasing age, which is primarily due to degenerative changes and risk of falls. Those are your two primary risk factors, and those account for the vast majority of labral tears. Incidence is unsurprisingly pretty high in the two groups you'd expect, overhead sports athletes and people of advanced age. You tend to see an uptick in people over 45 years of age, and then you see another uptick in ages above about 60. One of the interesting things I found is that labral tears have increased in number in about the last decade. It's not yet totally clear if that increase is due to an increase in prevalence or an increase in diagnosis. So are we seeing them more because they're happening more, or are we seeing them more because we're better at diagnosing them and therefore we're finding them more? And that it's not yet clear which one is the truth. So Bankart and slap tears are both different kinds of tears, and they're differentiated by the position of the tear itself. And we'll get into the specific positions of that here in just a moment. Bankart is named after a famed English surgeon, and SLAP is an acronym, superior labrum anterior posterior. It's one thing to say that, it's another thing to just see an image that makes it clear as day. And so we'll kind of go into a little bit of a description, and then I'll show some images. There we go. So they're typically referred to by their o'clock position. So if you imagine looking from the lateral position onto the glenoid fossa, and again, I'll explain this, but then we'll look at an image just to make it a little easier. If we go from 10 to 2, that's my 10 to 2, or I guess for the camera 10 to 2, that is superior, anterior, and posterior. That's a slap tear. I'm trying to do this from the camera's view. From the camera's view, if we go from 3 to 6, that's a Bankart tear. Again, it's one thing to say all that. It's another thing to just look at a picture. So let's look at a picture. So here we have on the left-hand side, we have this lateral view looking head on to the glenoid fossa with the clock face on it, helpfully. And then top right, we have a slap tear from 10 o'clock to 2 o'clock. So again, superior labrum, anterior, posterior, makes sense. And then the Bankart tears tend to be about 3 to 6 o'clock. Signs and symptoms: grinding, popping, or sticking of the shoulder, decreased range of motion, loss of strength, all very predictable. Symptoms include shoulder pain, a guarding of the shoulder. You'll see that people start to self-limit or self-allow only certain motions. There's this general feeling that they ought not to move it very much. And this feeling of instability, people report reaching out too far, either overhead or out from the body. There's this feeling that the shoulder might come out. And so people tend to, again, feed that back into the guarding. They tend to not allow the shoulder to go out too far as a sort of protective mechanism. Okay. Common tests and measures. A number of clinical tests exist for labral tears, though no individual test is both highly specific and highly sensitive. So what you tend to see is that there's a combination of tests that exist to really confirm the presence of labral tears. A number of physical examination tests, and then imaging studies, typically MRI. And we'll go over all this in brief. As far as physical examinations, you're looking at 3 really common tests: the O'Brien, the Speed, and the Jurgensen's. And then we'll go through a picture of each, and then we'll also show some imaging studies, MRI. So O'Brien test, the important thing to notice right here is where the patient has the arm. That's kind of the differentiating thing. So here it's extended out from the body, thumb pointed down. Speed test, again, arm out from the body. This time thumb is pointed laterally, palm is pointed up. And then the Jurgensen test, arm bent at about a 90-degree angle, palm is pointed down, so thumb is pointed medially. This one in particular tests the long head of the bicep. So you have the O'Brien, Speed, and Jurgensen's test. In all three of these, the same basic mechanism is true. The examiner places pressure against the arm, and the patient is then instructed to resist that pressure. In all three tests, a test is considered positive when pain is elicited upon resistance. Again, because no particular physical exam is both highly sensitive and highly specific, this is typically combined with imaging studies. And so we'll go look at a couple of those. Typically, the image of preference is an MRI. And so here we see an MRI of a slap tear from an anterior view. The thing you're looking for is in the red circle. There's this, what looks kind of like a black triangle. On the top side, there's that little bit of white. Oops, as I hit the wrong button. That faint white line is an indication of a labral tear. That's the attachment point of the labrum to the glenoid. The white is what indicates that it is maybe no longer quite so attached. So this is an anterior MRI view, and the next we'll move to a more lateral view. And you see the same thing. In this case, instead of a red circle, we have a red arrow, and it's pointing down. You see the presence of what looks like a labral cyst, which again is indicative of some kind of a tear in the labrum. As far as medical management, there's a number of treatment options, and they really do depend on the conditions of the tear itself, so the severity, the population you're talking about in terms of both age and activity levels. Less severe tears, particularly age-related labral tears, respond quite well to NSAIDs, so non-steroidal anti-inflammatory drugs, rest, and conservative physical therapy. That tends to be a pretty stable outcome for a lot of people. More severe tears, however, and especially with slap tears, if they're at all severe, don't tend to heal very well on their own. They really do need some surgical intervention to encourage them to heal. As you get to the more severe end of that scale, conservative options are not generally called upon as often. You really want to go the surgical route a little bit more often. Surgical repair is typically done arthroscopically. Much like describing the location of a Bankart slap tear, it's one thing to describe it, it's another thing to look at it. So I'll do both. I'll describe it, and then we'll watch a short little video. So arthroscopic surgery is done using an arthroscope. It's this kind of little projection fiber optic camera that's inserted via an incision. Forgive me as I forget all my words, through which the surgeon will view the surgical process. Again, it's one thing to use words, but 1,000 pictures for one picture, 1,000 words for one picture. Okay. So a quick image. On the left, you see the red kind of jagged line is the presence of a labral tear. The little hook is holding it open. And then towards the right, we see the red dotted line, which shows this kind of closure of that previous labral tear. And then kind of above it perpendicularly, you see the presence of a suture, which is used to kind of tie it down. And then another video, this one shows kind of the process of an arthroscopic repair, and I'll talk through it just a little bit. So again, you've got this anterior view of the shoulder, and then we're going to watch as it zooms back out. It'll show the epithelial layer again, and we're going to watch kind of as they do a couple sutures. So you'll see one anterior a little bit more medial, one anterior a little bit more lateral, and it's going to rotate around the back, and you'll see another suture on the posterior side. And I'm talking a little bit too fast for the video. And then again, the arthroscopic part of it is the idea that you're not opening up the whole shoulder. There's just these minimally invasive incisions. And then we're going to see the humeral head separate from the glenoid fossa, and you can see here the presence of this tear, pretty gnarly looking Bankart tear. And then here you go, you've got this little guy. This is the process of debridement. And so it's both kind of leveling out some of the jagged edges of the tear, and then also encouraging the surface level to bleed. By encouraging that surface level to bleed, it promotes the beginning of the healing process. And then here we can see anchors being drilled in. We're going to see a couple anchors. It'll show one, and then it kind of repeats them out. You see the suture being pulled around. And then what we're going to do is kind of pull that tight. And as it gets pulled taut, it kind of pulls that glenoid labrum back up against the glenoid fossa. And you can see here on the bottom 2/3, it shows that repeating a couple times. So it's repairing the Bankart lesion by pulling that glenoid labrum back to the end of the scapula, as it were. Buttons. Nope. Okay. Post-operative rehabilitation can vary widely. You're really looking at the qualifications that are dependent on how severe the initial injury and what the return of function is going to look like. Most people return to their previous level of function, though outcomes are slightly worse for overhead athletes. About 83% of patients report good to excellent results. Only about 73% return to their prior level of function. And amongst overhead throwing athletes, only about 63% return to their previous level of play. So again, for a large majority of people who might experience this, the functional outcomes are not super bad. For high performing overhead athletes, though, the prognosis is not quite so good. Here I have a couple of works cited, just in case anybody wants to double check my work. And this has been my presentation on Bankart and slap tears. Again, my name is Brian Havens, and this is part of the diagnostic module for SCT 101. Thank you.